There is a clear link between ethnicity and health. Ethnic groups have been and often identified as the other group, which means an identifiable group or groups who may be blamed for problems within a society or community. This is the sense of otherness which creates a lot of issues in these situations. These are the others who also carry the weight of undesirable moral, physical, and social characteristics or conditions and are mainly stigmatized for different situations. For example, they may be identified as dirty people, and people may think that they are unclean and therefore are associated with different conditions such as syphilis, AIDS, leprosy, or TB. In addition, they may be identified as immoral or ignorant, so therefore their health situations are not always taken as seriously as they should be. However, certain genetic conditions and other factors do also have an impact on the health of different ethnic minorities in any given country. For example, different groups have different needs, such as Afro-Caribbeans have a higher rate of sickle cell anemia than white Europeans, but they are less likely to be affected by hemophilia. Other important factor is that where migrants settle and what kind of areas do they settle in. It's generally that people, when they come into a new country, they may settle in areas which are already deprived and poor, and that has an impact on their health as well. Such groups are also at risk of undertaking risky physical labor, low status jobs, and therefore are usually at increased risk of injury and occupational diseases, and therefore ill health. Language is another important factor which acts as a barrier to access to health services. There are various strategies which can be used in population to reduce health inequalities. However, all of these strategies may not generally work with specific BME groups, and therefore these strategies have to be tailored to individual groups to make sure that their impact is as positive as it can be. In 2011 census, people were asked to respond to a question about their general health. They were asked to rate their health as either very good, good, fair, bad, or very bad. And the figure shown here is taken from census data, and it basically shows the number of people who have identified their health as not good health. And you can see various responses according to different ethnic groups. To some extent, the variability in general health in different ethnic groups can be explained by the difference in age in those groups. For example, in white ethnic group, there is an increasing population who is old, and with old age there are different long-term conditions associated, and this may explain why 20% of the population identify themselves as having not good health. Similarly, for white, gypsy and Irish travelers, the fact that people are moving from one place to the other very frequently, and therefore they may not always have access to healthcare services. Also, they have the number of old age people in their population is high, and all of these factors has an impact on how they identify their health. Perceptions of health among different people, what do they define as good health, socioeconomic conditions, and the ability to respond to different situations may also have an impact on people's ability to perceive their health as good, bad, or fair, or any other points. This graph is taken from 2011 census again, and this reports infant mortality rate by ethnic groups in England and Wales for babies born full term, which means babies born after 36 weeks of gestation. And the graph basically tells you that if we take example of Black Caribbean, so if we see 1,000 live babies, 1,000 births, so if 1,000 babies are born, the data suggests that 2 of them would die in their first year of life. So you can see from this graph that there is a variation in the infant mortality rate among different ethnic groups, with the highest rate in Pakistani population, where 3.4 children would die per 1,000 live births in 1 year. Again, there could be many different explanations of such variations, and there is some research which suggests that Black and Asian women have shorter gestations than white European women. And this may lead to earlier fetal maturation. However, discrepancies in gestation by ethnicity may also be explained by other factors such as economical factors, socioeconomic differences, physiological differences among different ethnic groups. Though the point here we are trying to make is that ethnicity has an impact on health, and this graph clearly demonstrates that. Let's look at some other examples. For example, cardiovascular disease. Evidence suggests that South Asian men are 50% more likely to have a heart attack or angina than men in general population. Caribbean men are 50% more likely to die of a stroke than general population. Let's look at cancer. Overall, the rate of cancer tends to be lower in Black and minority ethnic groups. The rate of oral cancer is high in South Asian and African groups that may be attributed to tobacco chewing or any other such habits. The rate of lung cancer is much lower in Black and minority ethnic groups, probably due to a lower prevalence of smoking in these groups. Similarly, breast cancer and the mortality rate associated with breast cancer is much lower in migrant women, and that there could be many different reasons associated with lifestyle and risk factors. For example, in some of Asian cultures, the women may breastfeed their babies for extended period of time, which seems to have a protective effect against breast cancer. Diabetes is one of the most common diseases in England, and the incidence is much more higher in minority ethnic groups. The prevalence, which means the presence of type 2 diabetes, is 6 times higher among South Asian population and 3 times higher among people from African and Caribbean backgrounds. Renal failure. End-stage renal failure or end-stage renal disease is 3 times more prevalent, or the risk is 3 times higher in South Asians and African Caribbean people. Looking at mental health, there are various ethnic differences, and it's one of the controversial topics. Most data about mental health issues in relation to ethnic minorities or ethnic differences is based on treatment rates, which show that people from minority ethnic groups are much more likely to receive a diagnosis of mental illness than white British people. Up to 7 times higher rates of new diagnoses of psychosis are among Black Caribbean people than white British people, and Black people are up to 6 times more likely to be detained under the Mental Health Act. 1 in 5 mental health inpatients come from Black and minority ethnic backgrounds, compared to 1 in 10 of the population as a whole. So just to summarize, that health inequalities in minority ethnic communities vary from one health condition to another. They differ across various age groups. They're different between men and women and between different geographical locations or areas, and between generations. First generation of migrants and the second generation of migrants, and so on. So, to sum up, there is ethnic variation in health and there are various explanations for it. For example, genetic and biological factors make a difference. There are certain conditions which are more prevalent in certain communities than the other. The examples could be sickle cell disease, thalassemia, coronary heart disease in Asians, diabetes, and many other examples like that. There could be differences due to individual behavior related factors or the cultural factors which may have an impact on people's lifestyle, their way of living, behaviors, and their dietary habits, smoking, drinking, and various other factors. So for example, white people or European people may be more likely to have been affected by conditions associated with smoking and drinking. South Asians and some of those ethnic group may have conditions most associated with lack of exercise or diabetes or any of the other factors. There could be material and structural factors such as poverty, bad housing, environmental conditions, which may not always relate to ethnicity, but that may relate to migration and people's ability to live in different places, and therefore has an indirect impact on ethnicity. So there is the double effect from both of these factors, which can then impact on their health. There are issues related to stereotypes and prejudice associated with migration and racism, which has an impact on the quality of care provided to individuals from different ethnic backgrounds. And one of the examples in such thing is that healthcare professionals believe that Asian communities, and especially Muslim Asians, let's take the example of Pakistani Asians, have got fatalistic attitudes when they talk about recessive conditions. That's one of the genetic conditions more prevalent in that particular community. And this is just purely a stereotype, because it's not that people would not want to do anything about these conditions, or they would say that it's God's will, that's why it happens. It is just their coping mechanism which they use to accept the condition, that if nothing works and nothing is possible to treat that particular condition, then you just accept it as God's will. And healthcare professionals often associate this as a fatalistic attitude and therefore may not be able to offer something. Such stereotypes and prejudice may also have an impact on screening of various conditions or identification of various conditions, or asking people questions about various things where healthcare professionals may think it's not culturally appropriate, and therefore they may not attempt to ask any questions, and the situations may get worse. And I think that's the end of this particular section.